Yeah, so probably the most important knowledge gaps currently are patient selection for interventions. As you probably know, in the last couple years, we've had quite a bit of progress in large vessel occlusion. In 2015, we had 3 trials that showed thrombectomy, or pulling the clot out of the occluded vessel, was beneficial. 2018, trials that showed that that was beneficial up to 24 hours from the stroke onset. Those trials have really revolutionized large vessel occlusion care. However, they are quite selective in the patient population that they allowed to receive the thrombectomy procedure. Specifically, there had to be a substantial amount of salvageable brain. And increasingly, we're wondering if patients with less salvageable brain, so more advanced or completed strokes, would benefit from these procedures. And there are 2 ongoing trials, well, one ongoing in Europe and then one that's about to begin in the United States, that will look at this more permissive inclusion criteria of patients with more completed strokes. That would allow us to treat a substantial portion of large vessel occlusion strokes that currently are not being treated. And I guess the other thing is that tenecteplase, which is an IV thrombolytic like alteplase, has been shown now to result in more resolution of large vessel occlusion, but it is not yet widely available in the United States. So when that clinical availability becomes reality, I think that too will have a big impact.
Yeah, this is very exciting. I mean, we both are stroke physicians, and all these studies have just allowed us to expand the patient population that can actually get these life-saving interventions. So.
It's a good question. Evaluating the cerebral collateral circulation is still a somewhat controversial idea, particularly when it comes to patient selection. We do know that patients with good collaterals tend to do better. They have better outcomes after their stroke. But compared to other technologies such as perfusion imaging or even looking at the extent of the stroke on CT or MRI, I would say that collaterals are still in a research phase more than a clinical care phase. Obviously, there are centers that do use collaterals and various grading scales, but they're in the minority, certainly. Mm-hmm. I don't know if you agree, Pete.
No, I totally agree. And I mean, in some ways, we're getting an indirect idea of what collaterals are through the perfusion imaging. It's mm-hmm. not specific to that. There could be a lot of things causing a good perfusion profile. But I agree, right now, it's not something we would make our decision on. Yeah. But we could in the future, who knows?
Yeah. And with the advent of multiple platforms that are now automatically detecting large vessel occlusion, so several vendors have software that can look at a CT angiogram and say there's a large vessel occlusion. The underpinning of that technology is that they're pulling the vessels out of the brain. And that's actually a pretty sophisticated thing for software to do. What that would allow would be a more objective measure of collaterals ultimately. Because if software can pull vessels out of the brain, it can also say, how many vessels are there after that blockage? And one thing in collateral measurement that has always been a problem is that it is subjective. It's human beings looking at it and saying, those collaterals look good, those look bad, mm-hmm. and there's bias inherent there.
I think this is a great question. The most important factors for medical students to consider when they're applying for a residency The first and foremost is really fit. We sat down and kind of tried to figure out what we thought the three kind of main areas for students to consider were, and we came down with logistics of the program, just pure nuts and bolts about how many residents there were, what the call was like, pay and benefits. The lifestyle sort of environment of the program, is it a kind of intense program? Is it more collegial? Do they really stress a work-life balance? How much time is sort of dedicated to exploring your own interests versus just taking care of neurology patients on the floor? And finally, the lifestyle of the area that you're going to, considerations for geography, what your spouse or partner may need, and family considerations and whatnot. So both
Fly to Utah?
Yeah, first and foremost, the best program in the world.
Yeah.
Again, it's all about fit. I mean, every program is going to be sort of a better fit for one individual over another, and that's what I tell them, regardless of sort of institution, brand name, or how big or small it is. It really isn't the most important thing. What's the most important for the student becoming a resident is how that program is going to fit their sort of needs, interests, family life, and whatnot. So I envision it just like getting perfectly fitted for the perfect outfit. You got to go out there and try them all on, meet everybody, see what you want to do, and it's got to be the best program for you. So
yeah. And I think too, in a very competitive environment for residency, medical students often get wrapped up in this idea of what is the best program that will take me, and that's natural to them because they're thinking, oh, if I could just get in this program. And I counsel medical students that they should step back and actually try to remove themselves from that competitive space and think more about, as Pete was saying, what program makes sense for me as a person and as a student. And that's very different depending on what type of resident they're going to be.
We tell them, and it's always sort of a revelation. You can see like the switch in their mind. Don't think just how valuable a program is going to be to you. Think about how valuable you are to that program. Each of these individuals brings a lot to the table, and they need to remember that.